Q&A.
Okay, so we've finished all the questions on the Google Doc, so we can open it up to questions again in the audience or online. So please submit your questions, raise your hand if you're in Sydney, or type your questions in the Q&A box. Thank you.
I'm just curious, I've seen that there's the self-expanding leaf expander. What's your opinion on these? I know they're not really present in Australia. Do they not have the same, you can't apply the same knowledge and move to them? It's sort of set and forget and not to a high enough standard?
So the question is, what about these NiTi expanders, right? So nickel titanium wires. No?
What she's saying, this is brand new.
Oh, okay.
I don't expect you to know. So, what she's saying is there is a new screw out there by Leone, right? That is, I have had, they sent it to me to trial out. It expands by itself. It's got like sort of how do you say, triangle?
I think so.
Yeah, NiTi spring in it, right? It's got a little clip that closes it together, so it keeps it together. And you put it in the mouth, and as soon as you release that clip, it automatically expands. You can't control it. There's no control. That's it. And you're in the hands of the screw, basically.
You won't get movement at each dimension. You'll just get a little bit of width. And is that why it's not taken off? That you don't get to control?
Yeah, I'm a little bit old-fashioned. I like to control things.
Yeah.
So
that makes
the
sense.
question is, what about these auto-correcting, expanding appliances, whether it be NiTi springs or whether it's a new device, whether it's Invisalign, it's just set and forget. So one of the things that I've learned is that when I don't know a product, I shouldn't make a comment. So I have no comment. But conceptually, what I love about my appliance is that it engages the palate and it engages the dental alveolar bone. And I can influence sutures on the top, and I can influence the dental alveolar form on the bottom. So I'm not interested in engaging teeth other than as a means of anchoring my plastic. So I love plastic. And I'd be interested if it has a lot of plastic. But if it doesn't have a lot of plastic, then it won't achieve my goals of trying to trick the bone into believing the tongue is doing all the work, right? So my appliances are tongue substitutes. Does everyone understand what I'm talking about? Tongue substitutes. The tongue is absent from this equation, and we have to take an understudy to do the job. Well, plastic bulky is as close as I have to appropriate understudy. And anything thin and refined and comfortable is not a tongue substitute.
Well, I guess, as you said earlier, the trickiest cases to treat are hyperdivergent cases. And I'm curious about what you see as predictable with what you can close with postural orthodontics and when you start to need to look at the surgical rotation you talked about, or even a stage 3 appliance. What's predictable?
Yeah, so over the years, I've worked out what are the minimum things I need in order for me to make the changes that I want. So your question was, in a hyperdivergent case, which is the most difficult, how do I know whether postural orthodontics will work? How do I know whether I have to do orthotropics? How do I know when to do surgery? And the answer is 15 years of experience has taught me how to figure that out. And I've got a system of how to work that out. And the way you can gain that experience is to let me hold your hand and go through and explain it to you. So we do that clinical exam. We do the clinical exam. We work out what the posture is. We work out what we're dealing with. We do the Ceph analysis. We work out what the degree of divergence is. We work out whether the nose works, whether the nose doesn't work, and we work out whether this is a family that will jump when I say jump and then ask me how high. All right. So those help me make those decisions. So it's not just how difficult is this case. I want to know how old is the child. I want to know how mature are the parents. Right? This single most important thing for you to diagnose is how mature are the parents. No, I'm serious. Do they let their kids take a hammer to the plate? Right? And how do they respond to that? So there are some things that can be done through mechanics. And there's a technique that we use in postural orthodontics where we extract primary teeth after we've intruded the 6-year-old molars and that closes the bite. But it only works at a certain age. It can only work for a 10-year-old after I've prepared it over the last 2 years. Well, sometimes it works well for an 11-year-old. Sometimes it even works well for a 12-year-old, so long as I've started at 9. All right, it's all part of the plan. And I've explained to the parents, you're going to have to send your kid to a GA, right? Have a pediatric dentist like Susan, extract the E's and the D's and the C's. Are you okay with that? I don't want my kid to have extractions. Right? So yeah, I can, but if they say no, then say no, then orthodontics. I do orthodontics. I can help you with orthodontics. Oh, I don't want him to wear that. Oh no, great surgeon. I have an answer for everything. It's just not necessarily what I can offer you. Another question is, have you ever used any fixed appliances? What's the major disadvantage of fixed appliances? So I was trained fixed braces, extraction fixed braces, 4 bicuspid extractions. Like POS, no tooth is sacred. Or if you've ever done POS, they have a motto, no tooth is sacred. We are happy to take out any tooth that meets our needs. All right, so I've used fixed braces, I've done extraction ortho, I've used RPEs, yeah, but I've never consistently got the results that I get using my system and John Mew's system in comparison, other than when I work with a surgeon. People say, what do you do when they come in and they're too old? I organize surgery. I work with a surgeon, Roland Barrowman. I work with a surgeon in Spain, Federico Alfaro, and I've worked with surgeons in the States. All right. We set them up, usually with fixed braces, and they have surgery. Sometimes it's SAPE, where we do the maxillary expansion surgically assisted first, let that heal, and then they have the maxillary mandibular advancement and counterclockwise rotation. So the goal is always the same. Get everything in the right place with its own space, and then teach them how to use it well. Whether it's an adult where we do surgery, same thing. Whether it's a little kid where we don't do surgery, same thing. Whether it's a deformed kid where I use orthotropics, same thing. It's always the same thing. It's not the appliance, it's the endpoint goal that I've set. And then how do I use stuff to get me there? Depends on how old the kid is, how severe the malocclusion is, and how mature the parents are. Okay, we are finished with Q&A.
Okay, let me hit the stop button.